कि वो कस्प का जो फोसा होता है उसका अलाइनमेंट और आर्टिकुलर एमिनेंस का अलाइनमेंट शुड बी द सेम इन प्रोस्टोडोंटिस्ट. दैट इज व्हाट वी वर टॉट, राइट? एंड that is the way you should design your cuspal anatomy for your dentures. Now if you go back 10 years down the line, you will say, oh, it was not at all true, right? I have listened to Okeson himself and he said ki that time that was okay, but now it's not. So most of the times what it is it the occlusion which is causing TMDs, or there is some muscle problem or TMJ problem which is causing disturbance in occlusion. So it's like a who came first, the chicken or the egg? Okay, there are n number of articles, but I would like to this article especially, Manfredini is an excellent guy, a lot of research in orofacial pain, and what they did was they retrospectively investigated all the articles on occlusion. Okay, all the articles from who related occlusion to TMDs from 1967. From then to around this was published in 2017, I guess. So till then they just compared all the articles and they came to a conclusion. And what was the conclusion? There is no major role of occlusion in the pathophysiology of TMDs. And this is what we were learning since so long, it's occlusion. कुछ होता है तो occlusion में गड़बड़ रहेगा. There is a deflecting cusp. Just remove the deflecting cusp and the pain is going to be solved. That's not really true, right? If you look at evidence based. Now this question also I get a lot. Sir, मेरा वो joint में clicking, popping हो रहा है, आवाज आ रहा है थड़, क्या करूँ? Right? So do you treat a asymptomatic click? That is also one of the very hot topics, and people are treating those asymptomatic clicks. But if you really want to go through literature, and there are huge number of articles, okay, if you see there's a separate mantra for it. If there's a TMJ click and there's no pain, don't touch that patient. You get my point? That I don't know, or nobody knows ki that clicking TMJ can convert into a TMDs or painful disorders. We don't know it yet. But if you start treating those TMJ clicks which are not painful, you'll definitely land up into a pain state or a TMDs. Do I need to reduce this volume? Yeah, okay. Right? So whenever your patient with TMJ click or TMJ third, what do you talk about, it comes to you and he doesn't have pain, don't go ahead and treat them, just reassure and explain them. See, there's multiple articles. There's this article wherein they just randomly screened around 100 patients and did an MRI for them, and they found out that 35% of the people have their disc anteriorly displaced, but they don't have any symptoms. They must be having some click or thud, but they don't have any symptoms. So do we really need to treat them? That's one thing we need to think about. But what evidence says, don't treat them, right? Then one more frequently asked question is about selective grinding, right? Now there's a whole complete group of people who think occlusion is the key, or occlusion is the one which causes this orofacial pain or temporomandibular disorders. So what they do is they have some fancy appliances. They put in the patient's mouth, they mark some points and they trim it down. Okay, they trim it down till the complete enamel is lost, and now the patient doesn't have TMJ, but he has dental pain now, right? So dental sensitivity. So we have to use our diligence and our brains, because evidence doesn't show, right? Orthotic appliances, orthotic appliances, what does it mean? Orthotics, orthodontists are here. Okay, orthotic appliances are basically splints. In a simple language, it's just a splint. Splint with a ramp, maybe a plain splint, maybe a night guard, whatever. Whatever appliances which you give patients for the relief of pain is called orthotic appliances. And sometimes they work beautifully, but you have to select the cases, okay? To select the cases, in which cases they are going to work, right? Not all cases are the candidates for orthotic appliances, okay? There's also a study on how oral appliances work in the management of temporomandibular joint disorders, okay? And what does the study say? See the conclusion. They can only be an adjuvant. So orthotic appliances you have to give till the time you diagnose that case properly. You find out the etiology, you treat it, right? Till that time you need to buy time for the patient to be away from the pain. So you have to give him something so that his pain is relieved. So by that time you can give an orthotic appliances. But then as a permanent therapy, orthotic appliance is not the way to go. They are just like a oromandibular crutches, okay? Like the patient with a fracture or maybe some ligament tear, you give those crutches, it is the same way for TMDs, right? This is what majority of articles, whenever you search on Google, you will find out. Now, this is the definition of pain. It's basically a sensory or emotional experience associated with actual. Now we know females have been dramatic since childhood, right? But then if you go into epidemiology and find out, around 90% of patients in orofacial pain and TMDs are going to be females. So whenever I am going to cater patients, there are 90% patients are going to be females, and this has been proven epidemiologically because they are genetically prone or genetically evident to have more pain. Okay. Now what I told in the initial time was everything in this region has to be TMG. That is what we feel. That is our choti soch. That is what I will say. Look at the amount of diseases or look at the amount of diagnosis we can have if you have pain in the preauricular area. Now there are these many things, and plus you can do multiple permutations and combinations, and there is going to be hundreds of diagnoses for orofacial pain, right? Just sum it up, okay? We'll just sum it up to a small classification wherein we divide pain into acute pain and chronic pain. Now acute pain, I called it acha pain. It's a good pain, okay? Why good pain? Because you can treat it, and we treat it every day. A dental pain, a periodontal pain, a mucosal pain. These are the pain which you can find out the etiology fast and treat it fast, right? But what about when it comes to chronic pain? Now this is the realm where we step in, okay? Or where I want each one of us step in so that we can help a large population of patients who are like, that patient who has been spending 6 months around from one dentist to another dentist, and somebody sent her to some psychiatrist and all those because they felt there is nothing which is causing you pain, you still complain of pain. Now if chronic orofacial pain is a totally different ball game, okay? In chronic pain you have musculoskeletal disorders, you have neurovascular disorders, and you have neuropathic disorders. Okay, musculoskeletal is basically the pain which is originating from the muscles of mastication and the muscles of your neck, back of the neck, and the cervical structures basically. Then you have tension type headaches. Tension type headache is also a musculoskeletal because it has been proven that people who drive for a longer duration, okay, with their neck unsupported, or people who watch telephone cradling. Okay, this is very new, and I've got many patients who have got sternocleidomastoid pain because of excess use of telephones and laptops and TVs. Okay, other is a neurovascular variant. That's a complete migraine and migraine type of disorders, or it's a disorder of a nerve which is supplying a vessel which is causing pain, right? This also we'll deal a small bit of this, and the last one is neuropathic, that is the pain which is emanating from the neural structures itself. Okay, so that thing Upasana ma'am is going to cover up. So let's define what chronic pain management, what do we need to work on. Okay, first and foremost we need to change our mindset, okay, because chronic orofacial pain is not a disease, first thing, okay, it's just a symptom, and you need to solve a symptom or maybe reduce a symptom or manage a symptom. As dentists we have been taught to treat. With these cases we need to manage them. We can't treat myofascial pain, just have to manage them because there is something in the muscle which is causing pain, and we just need to manage and just reduce the pain so that it's bearable for the patient. Also, when you don't understand, don't go ahead and drill a tooth when there is nothing which is showing on the tooth or on the x-ray. You need a competent OFP specialist or somebody who you can refer the case, who can manage or take care of the patient. It can be a neurophysician, it can be a physician, because there are n number of cases wherein we found out there is something is wrong systemically with the patient, and that is why it is causing pain to the patient, right? Now this diagram I like it a lot. Okay, that's a human homunculus. I don't know if you people are aware of it, but if you see that blue color markings, that's the sensory cortex. Okay, that is the cortex wherein all the pain from maxillofacial or any regions of the body is being taken and it is perceived as pain, because you don't call it pain until unless brain recognizes it as pain. Okay, once the cortex perceives it, then you call it pain. Now look at the area. So it's a huge area for a facial region, more than 1/3, and also your hands. You see that diagram? Because these, your hand and your face is bombarded with a lot of neurons which actually take pain sensation from your face, your hands back to the brain. Now why this has become a speciality, there is a reason for it, because there is a lot of neurons and conducting all the pain impulses back to the brain. What happens is sometimes there can be intermingling. So a pain from the lower tooth, patient may feel pain in the upper tooth. This must have happened to everybody, right? Yeah. Sometimes there is a deep caries and you say वहीं उसको RC लगना, and patient will say नहीं, my lower is not hurting, my upper one is hurting. Get my point? This happens because of this humunculus, because your brain perceives the pain as the upper tooth and you feel it is, and because of your diligence and your expertise in that field, you know it's for the lower tooth. Now is it different for male and females? Right? If you look at a male brain, see how much area we have got for females, and you say we don't respect females, right? Right? And look at this, a small area for asking directions. I hate asking directions. I really hate. Okay. Then what about the female brain then? Look at the area for shopping, right? And commitment needed, and we hate those. Like, those two fields well. And look at the small area for driving skills. Please pardon me, it's just to make you awake here. You guys have just got lunch, so I thought I'll put something so that you are all awake. Now, what is so special about why trigeminal nerve is so unique? Okay, and why orofacial pain is a specialty and not hand pain, right? Orofacial pain is a specialty because trigeminal nerve is pretty unique. Why it is unique? Because it responds differently to injuries. Now, if you have seen or been with orthopedic surgeons, if you have to amputate a small finger, whenever they amputate that small finger, what they do is they try and find out the nerve and merge it or bury it into the muscle and suture it back. Why do they do that? Because there is something called as a phantom limb syndrome. If you keep that nerve open, it is going to sprout and it is going to cause pain, which is called as phantom limb pain or phantom limb syndrome, and it is because of the traumatic neuroma which is caused by the sectioning of that nerve. But we do section a nerve day in and day out in our practice, right? You extract a tooth, what are you doing? You are pulling out the nerve, right? The end of that inferior alveolar nerve, you are pulling it out. And does your inferior alveolar nerve gives you that pain? It never gives, right? It doesn't give, because it's a very good way it gives away. That's the best part about trigeminal nerve. Now 90% of the cases you don't have trouble, but in few cases you have. That's a different topic, and that is what cases we get. Okay, but that is why it is so forgiving, your trigeminal nerve. There is nothing in the body as compared to what tooth is, and that is why dentistry is a speciality. Okay, right? Because there is nothing in the body wherein the nerve goes in and supplies your avascular portion, that is enamel and dentine, or takes away the sensation from the dentine, right? And now I don't know whether you guys are aware about autonomic nervous system, but if you know about autonomic nervous system, most of the major vessels have sympathetic supply more. Okay, because sympathetic is flight and flight, if you remember, and parasympathetic is rest and digest. So, but what speciality about trigeminal nerve is, or the area of trigeminal nerve is, the blood vessels which are supplied by trigeminal nerve, they have both parasympathetic and sympathetic. That is what is one of the uniqueness of trigeminal nerve, right? And you have got more fibers which are myelinated as compared to unmyelinated fibers. So these are the points which makes trigeminal nerve unique from the other nerves. Now let's get back to the case we had. Okay. Now it's the same case, right? She's complaining of pain. I don't know if it's audible. Do I need to take it?
कधी कधी इकडच्या साईडला पण जातं. सुचतात एक डोळे सुचतात आणि हे पण मग सुचतं मला असं
बरं
जड वाटतं मला
जड वाटतं हेवी वाटतं
Okay.
चालेल आणि आता मला फक्त दाखवा
Now last-
की ज्यावेळेस मी प्रेस करतो
I'm just palpating a sternocleidomastoid, okay, because of the history.
कुठपर्यंत चाललंय दुखणं
Now see where she's showing me the pain. I'm palpating the sternocleidomastoid, okay.
डोळ्यापर्यंत
She's showing me the pain in the
कानात पण
eye.
इथपर्यंत हेच तुम्हाला नेहमी दुखतं
हो हे दुखतं
हेच पर्टिक्युलर एकदम परफेक्ट जे दाखतोय मी
See? So what do we get it from now? Ki sometimes it's not always the site and the source has to be the same. The site of pain is in this region and the source is our sternocleidomastoid. Okay? Now it's very easy. The internet has made everything very available. There's a site called triggerpointinjections.net. If you want to write down, you can write it down and go and check on internet. Triggerpointinjections.net, and on this site you will see these particular muscles, the neck muscles, the face muscles, they have particular referral pattern. Okay, so patient can tell you I have pain in this region, but it can arise from sternocleidomastoid, it can arise from trapezius, it can arise from back muscles, even the masseter. You see, sometimes the patient has pain in the lower upper tooth or the lower tooth, and there is nothing in the tooth what we found out. It can be emanating from the masseters. Okay, we never have thought about it because we don't know it and we have not been taught about it. That is why it has to be a separate specialty so that people know about it, right? Now, okay, I understood it's rising from sternocleidomastoid. What next? Or how did I find out that it has to be sternocleidomastoid? Now the whole thing lies around is a proper history taking. Now what proper history taking I am talking about is, the patient told me, I just asked the patient, let's go back to 6 months down the line from where the pain started, and could you remember what were you doing 6 months prior or 2-3 days prior to when you had that pain? And patient told me, yeah, that I do remember, but nobody asked me what I was doing. They just, whenever I came, they said pain and they started drilling. This is what we do, right? Maybe we have a lack of time and that is what we are doing it. That's too wrong or very injustice on the part of the patient, right? So what we did was, once I went back to the history, she told me that, sir, I am a teacher by profession, and then because there were a lot of 500 papers I need to check in a span of 3 days, and I just put my head down and I was just, only for the coffee mug I used to get my head up. So this continuous posture, okay, this caused a lot of pain on our sternocleidomastoid, and nobody asked it, right? Because we didn't go into history of the patient only. We saw caries, we started filling it, and that was the etiology. So what I did was, I first advised her for a posture correction. Okay, I told her, you don't need to bend so much, you have to just correct your posture. I gave her good how you can stretch your muscles, and this was the last piece which was missing in our diagnosis, right? The history, proper history, because our posture was our problem, and plus what we did, 2 hours of long appointment stretching it like this. Get my point? That even worsened the pain, right? So for diagnosis and management of these cases, there are multiple modalities if it's a muscle pain. First is, you find out the etiology first, okay, and rule out any systemic involvement, because vitamin D deficiencies or even iron deficiencies have proven to cause myalgia pain or muscle pain. Okay, what you can do is, you just have to educate the patient, explain the patient. You can have cold therapies, hot therapies. There are multiple modalities: TENS, ultrasound, physiotherapy. Orthotic appliances for sternocleidomastoid I won't recommend, but then to buy some time you can, and pharmacotherapy. So what did we do with the case? Just check it. Now I could find out there was a trigger point or a trigger zone in that region of SCM, and which was referring the pain to the eye and the TMJ and preauricular region. I just injected a trigger point injection. I don't know if anybody of you is aware of it, but Google is very fast. You go and put the trigger point injections and you will come to know. Now in trigger point injection, you can inject a plain local anesthetic, or you can just do a dry needle and release those trigger point. And 2 injections followed in a week's time, and the patient was all well to go. But she's again going to have pain in that SCM, but if she follows her posture properly and follow all the physiotherapy which I have given her, then probably the pain won't be there. And she understood that the posture which was wrong caused me pain and not anything in the tooth. Got my point? Sorry. ये कुछ नया था, राइट? या था कि नहीं था यार? सब सो गए. I want big noises. Thank you. Okay. Do you want one more case? Wow, good. Okay. Now here comes one more female. See, I told you there is going to be female 90%, and I have got 100% females in my cases today. So it's a 55-year-old female. She complained of pain and swelling in the gums bilaterally. Okay, the second molar ke piche. Okay, since last 3 months. Okay, there is a continuous dull aching pain in that region which she is saying. Okay, there is no caries, there is no infection to the socket. The 3/8 and 4/8 were obviously extracted for that pain only, but then the pain never went back. Then she also complained of pain in the TMJ region. There was no pain elsewhere, and there was also clicking. There was no clicking on opening, but there was some pain on mastication, which she said. So now, if you see the case which we saw prior, what can emanate? What would you get? Masseters, right? Can masseter cause this type of pain, which I told you? Pain in the lower teeth or the upper teeth posterior, right? Typical referral pattern, right? So let's see. From now, we come to know it has to be something with the masseter which is causing it, right? Now, what do we do about this case? What we can do is we can put the patient on muscle relaxants. Is it helping? Till the time she is on muscle relaxant, it will work. Can I do selective grinding? Are you going to do selective grinding? I don't hear a yes, I don't hear a no. Okay, great. So that lecture safal ho gaya. Are you going to give an occlusal splint? You might, yeah, you might, but to buy time, but you need to find out the exact diagnosis, right? Arthrocentesis, because we know दांत में नहीं है तो joint में है, so you have to do arthrocentesis. But we are not going to do it because we know the science now, right? TMJ surgery, that's out of question. I do it, I love it because that's my daily base doing. And the last thing is what we do. Patient psycho है यार, भेज दो दूसरे dentist के पास, it will be his headache, and don't come to me, right? So how do we go? Then I took a medical history of the patient. The patient is on anti-hypertensive medication which is under control. She is asthmatic and she takes her Rastylane. Okay. Now when I palpated these muscles, they were all painful. Not even this side, even the opposite side was painful. And all her neck muscles, including her calf and deltoid muscles, everything was painful. Okay. So now if I have to give a trigger point injection, I have to give it to all muscles. Right? Is it feasible? So now we have to also she had some additional complaints like dry mouth, sleeplessness, acidity. I write it down everything, okay, whatever complaint. No patient is psycho, I'll tell you. All psychogenic pain is because we don't know the diagnosis. The patient is not psycho. You get it? So these were the additional complaints she had. Now is there something we are missing? There's some missing piece in the diagnosis, that is why we are not able to see it. Now this patient actually had a drug-induced myofascial pain. Because I went back to the history and I asked her anti-hypertensive medications were recently changed, 4 months down the line. Okay, she's been having pain since 3 months. Now 4 months prior, the medicines were being changed and she was put on this diuretic. Diter is a diuretic. Okay, and it has got a propensity to cause myofascial or facial or muscle pain. Okay, if you see this is an article, I have just googled it. Okay, just google it, ki what are the side effects of Diter, and look at those: dizziness, leg cramps, dry mouth, loss of appetite, muscle pain, sleeplessness, excessive urination. Do I need to treat this case? I just need to call the physician and tell him, boss, whatever drugs you have started, it is giving side effects to the patient. That is why she is having muscle pain. By that time, we can do some physiotherapy for that patient. But as the physician changed the medication, within a span of a month, she was all okay. There was no muscle pain, there were no cramps. So you have to use your diligence, right? And what a splint is going to do, or what trimming the teeth is going to do with these cases. These are the cases you are going to get in your day-to-day clinical practice, I am telling you. Every case is a orofacial pain case. That is the way I started looking at since last 4 years, from the time I joined the program. Okay, that was good, right? Okay, the last case for the day, because Upasana ma'am is very eager to talk. Okay, again a female, and this was the case which made me enter into the field of OFP. I'll tell you, this is my friend's, very dear friend's wife. She's been suffering for this pain in the left premolar region. Now what the current scenario was, she used to tell me, वो जो gums होता है ना in the lower premolar region, वहाँ पे से pain शुरू होता है. Then the pain goes to the upper premolar gums, and then she has a whole full-blown headaches. And it was so severe that she had to be admitted to the hospital for this pain. It was that severe. And then we couldn't understand that time, because I was also in the same line as you, everybody of us are. Then we saw कि उसके third molar impacted है. Probably that would be one of the reason. But she was deeply in stress, and the quality of life was severely affected. Okay. The only thing I could find out was एक premolar उसका rotated था. But I don't know that would cause a pain. Now, because of pain, I told him, let's get your third molar extracted, because I had the same concept कि वो push कर रहे हैं, and that is why you are having pain in the premolar region. So I only extracted those third molars, upper and lower, I'm telling him. Okay, but then she had no relief. Okay, in spite of that, no relief. Then they stay in Mumbai, I stay in Aurangabad. So then I told her to show to some dentist. The dentist said, we'll give an appliance. So I said, okay, you try an appliance, because it's an irreversible procedure, so it's better. For 15-20 days she was relieved of pain, and again the pain continued. Okay, then somebody suggested that there must be some hidden caries, or there must be some fracture with the tooth. Let's try a root canal. Okay, so they did a root canal with the 3-4, and then the pain was not solved. They again did a root canal with 3-5 as well. Okay, the pain still continued. Then they thought, let's extract 3-4 and 3-5. Okay, so this is what happens. This is my friend's wife, I am telling you. And then what I did was, I took the patient to the course, okay, where we were doing the course, and I showed it to our boss, Dr. Davis Thomas, and then we came to a diagnosis, which was from here, because then he asked very peculiar questions to him. Do you feel whenever you are going to have the pain? That is called an aura. Aura is typically there in cases of migraine, but migraine, if oral medicine people must be knowing it, it generally happens in this region, okay, unilateral, but around the eye and temple region. It never comes onto the teeth. But this was a special variant called as mid-face migraine. And even my mentor, Dr. Davis, was very surprised to see this case. We are going to publish this case. It is called as migraine or mid-face migraine, or NVOP. NVOP is neurovascular orofacial pain. It's an entirely new entity, but it will blow your clinical practice if you see such cases. Okay, so these are very stringent cases, and they'll complain of tooth pain only. But you have to know the exact severity and the bouts with which the patient is having this pain, right? Migraine, I guess I won't talk about much, but you need to know it. Summing up, now I'm going to ask the same questions again, whatever we did. Are all orofacial pain TMDs? Great. Occlusion and orofacial pain, is there a relation? Perfect. At times, okay. Do you treat asymptomatic click? Are you going to from tomorrow? No. Thank you. Then, are you going to irreversibly cut the enamel of your teeth? No. Until and unless you have a definitive diagnosis. Okay. Orthodontic appliances, yes, at times they are helpful, but they are only to buy some time till the time you have a confirmed diagnosis, right? Evidence-based management is the key, okay? You just need to have a proper history. Sorry. The success ladder for managing any OFP case goes like this: accurate history taking and first come to a diagnosis before starting any treatment. We do the exact opposite. Patient aaya, drill karo, fill karo. It doesn't work that way. You identify and manage the underlying etiology and select a proper management protocol, right? A simple take-home message is, don't be just a mechanical dentist, okay? You are, because people rely on you because you are a stomatognatic physician. If you feel that way, okay? Because you need to diagnose it, right? You are diligent and don't treat any teeth without any definitive diagnosis. Learn to refer, avoid doing irreversible damage to the teeth, and all these things which we talked about, all the three cases, they are not very simple to diagnose or dissect. It's only a single etiology. Sometimes TMDs, muscle pain, they all overlap and come in together with even sleep disorders, OSA. It's a very high in chronic pain. So even sleep medicine is attached to it because we have a degree of sleep medicine as well. So, and you need to keep upgrading yourself. That is what I always feel, because so much new you came to know today, because you must not be knowing it prior to this lecture, I feel. So you need to upgrade. You have to think if you want to be a Nokia 3310 or you have to be a Samsung Galaxy. So that's your choice, how you upgrade yourself and how you get yourself. Thank you so much. I guess I'll pass on to Dr. Upasana. Any questions, we'll take it after her lecture, I guess.
Thank you, sir, for sharing us with your knowledge. Now I call upon Dr. Upasana ma'am to proceed with her lecture.
Hello everyone, is my voice audible? It's audible? Yeah. At the outset I would like to thank Dean of the Institute, Anand Shigli sir. Thank you so much sir for making such elaborate arrangements and giving us the opportunity to speak to everyone and introduce the youngest member, that is orofacial pain, to the dentistry world. I am calling it as the youngest or I can, yeah. Sorry? You give me the hand. I call orofacial pain as the youngest member of dentistry because very recently, just last year, it has now been introduced as the 12th specialty of dentistry in US. And we wish and we hope that this science gets its due and its importance in our country as well. Okay, so when we talk about dentistry, I'm just going to take 15-20 minutes, so please just bear with us. So when we talk about dentistry, what comes to our mind? Interns, can we just interact a bit? When we talk about dentistry, I'm not talking about orofacial pain. When I say dentistry, what comes to your mind? Absolutely, root canals, braces, implants, restorations and everything. Okay, so probably that's the bread and butter of a dentist. So this is the first thing that comes to our mind. And whenever any patient comes to our clinic, that is the first thing that we try to see, and so that we immediately start with the treatments. So now let's go through few of the treatments that we do routinely in our dental clinics. If I may ask you about the root canals that have been done here, can you comment on these root canals? This particular patient came with pain, and I presume, and I can see that the root canals that were done for these patients were excellent. Sir, am I right? Okay. So then for this particular patient, the pain was relieved, right? Coming on to the next case. If you see the first OPG, this is the case of impacted third molars. Again, this patient had come with a problem in the impacted third molars and wanted to get the teeth removed. And if you see the first OPG, we can see there is some approximation of the third molar to the inferior alveolar canal. Probably for this particular patient, it was told that you might get a nerve injury while disimpacting this particular teeth. So patient was already told beforehand, but then somehow nothing eventful happened for this particular patient. Now if we see the second case, the second OPG, here we see that the third molars are at a quite decent distance from the inferior alveolar canal, and routine disimpaction was again performed for this particular patient, and patient was relieved of the trouble which was caused by the third molars. Coming on to the next case, wow, implants. Everybody looks forward in a clinic, in a private clinical practice doing implants. So when this particular patient again came for the implant procedure, the dentist was very happy, the implantologist was very happy seeing the quality of the bone, and the implants were on the contralateral side. Just try to poke a little bit, just try to make so that the patient can elicit the response. If at all, with the same pressure, do it on the contralateral side. If at all the patient doesn't feel any sensations, or patient feels hyperalgesic with the same amount of force that you have used, then it could be again one of the signs that patient has developed some sort of neuropathy. You can also do it in our practice, like you can do it with hot and cold. For hot, you can use a simple GP we have in our clinics, and for cold you can use ethyl chloride. Just spray a little bit ethyl chloride on a pellet of cotton, and then again on the contralateral side, touch the area. Patient would feel sensations. If you see it on the other side, the affected side, either it will be hypoaesthetic or it will have a hyperalgesic response. This is a very interesting thing, mapping. Mapping is very important both diagnostically as well as therapeutically. Mapping is what you need to localize the area, the hypoaesthetic or hyperalgesic area. So what you do is, that's how you draw. Can you see this? This is pre-treatment. This is the particular area where the nerve involvement was there. Click nice pictures, localize the area, and then later on, once you start giving the treatment, if you want to now further see whether the treatment was effective or not, you can you need to do the trigeminal nerve testing, both the sensory and the motor component, and then again you see if the area has reduced in size or not. Reduction in that particular size of the lesion in itself tells us that yes, the treatment was effective. This I have already mentioned, the neurosensory testing, pinprick, and you can do it with hot and cold. Qualitative sensory testing, that is a QST modality, it is very sensitive, and it utilizes a lot of equipments which is not readily available in our routine clinical setup, but then that's considered the gold standard to analyze the sensory function of a nerve. It has certain parameters that is the hold, hot, cold and the mechanical parameters, which we compare it to the normal values, and then assess whether the nerve is normal or it is abnormal. And then the lab test. Why have I mentioned lab test? See, because whenever you are suspecting neuropathy in a patient, always rule out the systemic causes, because it is not something which happens very routinely. And what all those systemic causes could be, the first and the foremost and most common being diabetes. Diabetic neuropathy again is very common. Any patient who has history of diabetes, look in for any symptoms, any sign and symptoms of neuropathy, rather than just arbitrarily rendering any treatment to the patient. Then there might be other causes like even hypothyroidism. Hypothyroidism also in due course of time shows certain symptoms of neuropathy. So then how do we manage? Once we know that this is a case of neuropathy, how do we manage it? Our aim should be to manage it as much as possible with the conservative and medicinal treatment. And for that, we have certain medicines, like we can put the patient on gabapentin and pregabalin. But before that, suppose while you are doing a surgery, while you are placing an implant or you are doing an impaction, and you come to know that you have hit the nerve, immediately patient will say, yes, I felt the prick. Immediately you need to stop the procedure, and then make sure that you withdraw the needle, and then you take some more precautions, and then go ahead with the surgery. But once you have caused injury to the nerve, the best treatment at that moment of time is that you put the patient on Medrol pack. Or else, for example, if at all you have treated a patient, the next thing what you do is, you always make sure that within 12 to 24 hours, you call up that patient and you ask, or you call the patient to your clinic and look for any signs of paresthesia or hypoesthesia. Because that is the time frame, that is 12 to 24 hours is the time wherein if you render the treatment to the patient for neuropathic pain, the treatment will be most effective. So in such cases, what do you do? In such cases, you put the patient on a Medrol pack, that is methylprednisolone, which is a corticosteroid. And in Medrol pack, you have to give initially very high dose and then taper it down in a span of 6 days. First day you give 6 tablets, then 5 tablets, 4, 3, 2, 1. And that's the way whatever injury has been, accidentally, whatever injury has happened to the nerve, that is the way it can best heal. Once that duration is gone, a week or 10 days is gone, longer the duration, lesser the chances for the nerve to regenerate. We all have read that it is very difficult for the nerve to regenerate. So if at all we have by mistake caused any trauma to the nerve, the first and the foremost thing is to start the treatment as soon as possible. This is the Medrol pack, that is, you need to give it in a tapering dose. And then the other things that we can do is, we can put the patient on NSAIDs. But then this NSAIDs is not for 3 or 4 days. This is what we do, maximum we do. After root canals or after disimpactions, we tell the patient, take painkillers for 4 days. These are not only analgesics, these are also anti-inflammatories. We need to ensure that the nerve is completely free of inflammation when we are treating or when we are suspecting any case of neuropathia. Then there are certain neuropathic pain medications also available, like gabapentin and pregabalin. But then again, we need to closely monitor when we are putting the patients on these medications. And there is a concept of preemptive analgesia. Again, in cases where we are suspecting a lot of inflammation, it is better to put the patient on analgesics before we start treating the patient. That will take care of the initial inflammation that is happening in and around the tooth, and then later we find that such in the cases where we put the patient on analgesics, the chances of neuropathy it reduces. In fact, now there are many clinicians who are following a protocol of putting the patient on corticosteroids a day or two prior to surgery. This also reduces the chances of patient getting neuropathic pain. So the take-home message for us when we are treating the patient is First of all, listen to the patient. If the patient says that, yes, I have feeling of discomfort, I have burning, I have like pins and needles after the surgery, just don't avoid it. Please make sure that you listen to the patient and take a very prompt action. As I mentioned previously also, it is very important to manage patients with neuropathic pain in the initial 24 hours. The best treatment that we can do is in the initial 24 hours. Then acknowledge injury. If at all it has happened by mistake or it's iatrogenic, it's fine. It can happen because most of the dental procedures are blind. So if this has happened, there is no big deal. We just need to acknowledge and we need to start the treatment. Then early referral and diagnosis and the treatment. If at all you feel that it is difficult for you to manage such patients, immediately refer the patient to an orofacial pain specialist rather than just lingering on with most of the times what we see is we put the patient on methylcobalamin. This is so common, so commonly seen. Any nerve injury, put the patient on vitamin B12. Ho jayega dheere dheere. No, nerve will never heal if you just put the patient on vitamin B12. With this concept of what Dr. Nilesh has told us about the pains being referred from the muscle to the teeth, patients of neuropathic being referred to our clinic or being seen by all of us, we are conducting a 3-day module from tomorrow in Hayat. This is going to be a very comprehensive module where we'll be dealing with all sorts of patients who have pain of non-dental origin. So that would encompass complete range of patients like neuropathic pain, muscular disorders pain, patients with TMDS, that is temporomandibular joint disorders. And then after we have a knowledge about all these cases, we are going to conduct a hands-on module, and we are very fortunate and we are very thankful to Shigli sir, who has consented that we will be doing the hands-on in your college, that is day after tomorrow. But then for the hands-on, it is very important for us to have first a background of what we are going to treat. So in the hands-on, we are going to do trigger point injections, what Dr. Nilesh showed just now. We are going to teach you spray and stretch techniques, which is very common for the muscular disorders again. We are going to learn various types of splints being fabricated for patients with temporomandibular joint disorders. So these are our faculty for the course. Dr. Sumit, he's again a diplomat. He is practicing in Dubai. Dr. Prisley, he's a prosthodontist from Kerala. Myself, Dr. Nilesh, whom you've met very recently, and Dr. Ame, who is an orthodontist. The course fees for this particular 3-day course in Hayat that we had kept is 40,000. But then since we have conducted 1-day module here, and because sir has been magnanimous to offer hands-on in the college, we can offer this course, anybody who's interested, for 20,000. So anybody who's interested, please do let us know. Thank you.
I'm sure that our audience now have been aware about TMD and orofacial pain, and I once again thank our guest speakers for walking us through the session on orofacial pain. Thank you. Now I call upon Dr. Malia, Lecturer, Department of Prosthodontics, TYPDS, to proceed with the vote of thanks and conclude our program for the day. Thank you.
Good afternoon to one and all. Myself, Dr. Malia, Department of Prosthodontics, deem it a great honor and privilege to propose the vote of thanks for this occasion. First and foremost, I thank Dr. Anand Shigli, Dean, D.Y. Patil Dental School, for helping us conduct this resourceful session. I would like to extend our sincere gratitude to the Indian Academy of Dental and Facial Pain and resource persons for the session today, Dr. Upasana Sethi and Dr. Nilesh Deshmukh and Dr. Amay Rati for enlightening us with their knowledge. My heartfelt thanks to the head of various departments and faculty for their valuable contribution and encouragement. I owe special gratitude to the non-teaching staff who had worked hard to ensure that this occasion become a memorable success. Last but not the least, I thank all the postgraduate, undergraduate students and my colleagues in making this function a memorable success. Once again, I thank you all for your kind attention. Thank you.